just going to record. Thanks everybody for coming to our Schulich Grand Rounds today. We have Dr. Piroze. I had trouble pronouncing his last name, so maybe he'll do it himself, from Toronto General Hospital. He's the director of minimally invasive cardiac surgery and just started being recruited back to Toronto. So he graduated from medical school in India in 1993, then followed by general residency. Also did a master's in general surgery from University of Pune in India, and then did his residency and obtained his degree from Mumbai. He actually was in Toronto from 2000 to 2003, and actually kind of was at Sunnybrook and knows a lot of our surgeons here, and did cardiovascular fellowship. And afterwards, he spent his time at Leipzig Heart Center, Germany, where he was the lead senior consultant, director of bypass surgery up to 2011. So he got recruited very recently to start the minimally invasive surgical program. He's interested in clinical research as well as also endocarditis complex surgery. He's a member of esteemed societies such as the ATS, European Association of Cardiothoracic Surgery, as well as International Society for Minimally Invasive Cardiothoracic Surgery, and also a fellow of the American Heart Association. So thanks a lot. He's going to give us some introduction about minimally invasive surgery and what he's going to plan to do over the next few years. So thanks a lot for coming.
Thanks a lot, Dennis, for the kind invitation to present at the Grand Rounds. And it's good to talk to some of the colleagues, I guess maybe online, with whom I worked almost 20 years ago. So the topic today was just to give you an overview of minimally invasive cardiac surgery. So what is sort of possible, what are the surgeries, what are the approaches, and a few advantages, disadvantages, and a few results of these kinds of surgeries. So okay. So as you know that surgeons are most comfortable doing a cardiac operation through this incision called as the median sternotomy, because it gives access to all the structures of the heart, the great vessels, and also gives a comfort level to the surgeon, because in case of any complications, he has a better grip on the situation and can sort of get out of a complicated situation most of the times without any trouble. But again, it comes with its own disadvantages. We know the sternal instability could be a problem. Wound infections are often seen at least in 1 to 5% of the patients undergoing sternotomy, and sometimes can lead to life-threatening complications like osteomyelitis and mediastinitis. And of course, it's known that sternotomy requires a prolonged recovery, anywhere between 3 to 6 months. In order to overcome all these disadvantages of sternotomy, the minimally invasive cardiac surgery was developed especially on the back of laparoscopic general surgery. And these types of operations are performed through different approaches depending upon the type of surgery that is performed. And the most common approaches used are a left anterior thoracotomy for CABG, right anterolateral thoracotomy for a mitral valve, tricuspid valve surgery or ASD closures. And for the aortic valve or aortic surgery, we can use a hemisternotomy, or we can use a right anterior thoracotomy approach. Now, there are certain goals of minimally invasive surgery, and one of the main ones is to achieve better, if not similar outcomes to conventional surgery. So, for example, you should have a high repair rate in mitral valve repair surgery. A valve replacement should be efficient and efficacious. And of course, when you're doing a bypass, the graft patency rates should be as high as those seen after a conventional CABG. At the same time, one has to maintain the highest patient safety. And in order to achieve these results, optimal visualization of the structure that you're operating on is of paramount importance in sternum sparing incisions. Because if you can see what you're what you're operating, then obviously you cannot get the best anatomical and clinical result. And finally, it has to be minimal access. So you cannot do a 15 to 20 centimeter thoracotomy and say that you're doing a sternal sparing approach. That doesn't serve the purpose. So it has to be truly a minimal access surgery. There are certain advantages of minimally invasive surgery. I think the most important one is it minimizes surgical trauma tremendously, and this translates into a reduced blood loss and reduced transfusion rates. Decreases post-operative pain. Now, this has to be taken is a caveat to this, that in the initial 4 to 7 days, the post-operative pain may be more than you would experience after a sternotomy incision. But then over the period of 2 and 3 weeks, the pain reduces and the recovery is extremely quick. Another advantage is that post-operative respiratory function is maintained because we basically do not alter the mechanics of breathing, because there is no rib broken or cut, and of course the sternum is stable always because it's not touched at all, and that enhances the post-operative respiratory function. There is an extremely low incidence of wound infections. Even if you use bilateral ITAs, you pretty much have very, very, very negligible, close to zero wound infections. And one of the main advantages being early mobilization with a potentially shorter hospital stay and quicker recovery, especially in young patients who want to get back to work, or even in old patients who are living alone. They want to get back to their feet as soon as possible so that they can take care of themselves as soon as possible. Another added advantage is that it facilitates reoperation at a later date. So if you go in a patient who has undergone a previous minimally invasive surgery, the sternotomy approach is pretty much like a first-time operation because the entire area of the sternum is a virgin area, and it poses minimal problems. And as an added benefit, of course, it provides superior cosmesis, but to emphasize that that's not the reason why you do minimally invasive cardiac surgery. So we'll first look at minimally invasive mitral valve surgery, and common sense tells you that when you want to access the mitral valve through the sternotomy incision, you have this angled vision. So you have to perform a number of steps in order to expose the mitral valve. And many a times, the surgeon is the only guy who can have a view of the mitral valve. Whereas in a minimally invasive approach, when you approach from the right side, you see that it's almost a straight shot of the mitral valve, and just elevating the interatrial septum exposes the mitral valve very well. And this is just to show you what kind of view you have when you're doing a minimally invasive mitral valve repair. You can see both the leaflets. You can actually see details of every aspect of the subvalvular apparatus. You can assess the valve very well, and the most important thing is that each of these pictures that you see is blown up on a 40 to 50-inch screen, so the entire operating room can see it. Even the anesthetist doing echocardiography can see it, and everyone can participate in the operation or decision-making process as well in highly complex cases. And of course, it's an excellent tool to teach residents because they can see every step that you're doing during the mitral valve repair or replacement. So the indications are any isolated mitral valve replacement or isolated mitral valve repair can be performed through this approach. Even the complex Barlows can be performed, as I'll show you later. Secondly, it's a great advantage in doing redo cases in patients who have undergone bypass or AVR, uh, especially AVR, because exposing the mitral valve in a patient who has undergone AVR is extremely difficult through a sternotomy approach, and this approach provides a much better exposure. And of course, concomitant procedures like tricuspid valve surgery, especially repair, AF ablation surgery, and ASD closures can also be performed simultaneously. This is just to show you a clip on how we approach the mitral valve. So this is just a P2 prolapse. I'll just run along. So we give us left lateral position is about 30 degrees left lateral, and we make about a 4 to 5 centimeter incision, enter the thorax through the fourth intercostal space, and use a soft tissue retractor. Most of the times we do not need to use the metal retractor at all. So here is a very small incision in the groin, exactly on the femoral arteries and vein, and that is used as an access site for establishing a cardiopulmonary bypass. Here you see the arterial cannula going in. So once the patient is connected to cardiopulmonary bypass, the pericardium is opened. You can see the heart is totally empty and beating. And here we put in the cardioplegia purse string in order to insert the cardioplegia needle for the delivery of cardioplegia so as to arrest the heart. So here you can see the cardioplegia needle, which is brought out through a small puncture wound, which is an access site for various instruments as well. Later on, you will see. So we take a small a retraction suture just above the right superior pulmonary vein, and here we have opened the left atrium. Mind you that the aorta is already clamped, and here you see that you don't even need to open the left atrium as you open it up for conventional mitral valve surgery through a sternotomy. So just by this, you can see the retractor is being pushed in through that puncture wound that I told you about, and here you can see the entire mitral valve on your screen. So you assess the mitral valve. Here you can see the P2 prolapse. And so what we used in Leipzig, which is now commonly known as the Leipzig loop technique, is to produce neocords. These are polytetrafluoroethylene cords that are used to assess to fix the prolapse segments of the mitral valve. And here you see these are the loops which are attached or sutured into the tips of the papillary muscle. And usually I prefer to use a set on either side in order to respect the midline. And once these loops are attached, then these free end of the loops are then attached to the free margin of the prolapsing segment of the posterior leaflet in this case, but you can use the same technique for any segment of the mitral valve. And you can use multiple loops. Each set of loops has 4 loops. So we have in total 8 loops that we can use. And depending upon the extent of the prolapsing segment, you can vary the number of loops that you use. So here you see that the loops are being now passed through the free edge of the leaflet and it's tied down. Here you see an instrument that's coming down that's known as a knot pusher. It's not possible to knot with your bare hands because of the distance, and this instrument is used. So once they are placed, you cut off the sutures, and basically your leaflet repair is complete with this. So this at this point you just check the valve again just to see whether the posterior prolapse has been corrected. It's not to assess the competency of the mitral valves. So once you've assessed that and confirmed that the prolapse has disappeared, then we take these sutures into the mitral annulus for performing the ring annuloplasty. So most of the times in Leipzig, we used to always perform a complete ring, but in certain situations, you can also use a open ring or a band, especially in patients where you're worried about SAM. So just run along a little for the sake of time. So here you see that the sutures have then been passed through the ring. The ring has been lowered, and we use this specialized knotting technique, which is known as core knot, which facilitates minimally invasive repair, and then again test the valve at the end to confirm that the line of closure is posterior and is parallel to the posterior annulus. And following this, the left atrium is then closed, and here you can see the repaired valve. It is a good line of coaptation. What is important, you see that both the leaflets are mobile, unlike in a resection technique where usually the posterior leaflet becomes fixed. So we pass a pacing wire as well at the end and close the pericardium. And once we close the pericardium, we come off the cardiopulmonary bypass. And yeah, that's the end of the operation. This is something, a paper that I published a long time ago, like in 2013, from the Leipzig experience. It was a total of about 3,500 patients, close to 3,000 undergoing mitral valve repair, and about 600 odd patients undergoing mitral valve replacement. Now, if you look at the mitral valve repair group, we always use a ring annuloplasty, and majority of the times a complete ring. And there were also combined procedures performed. The 30% of them received a cryoablation for atrial fibrillation, and about 10% received a tricuspid valve repair, and the same number approximately receiving also ASDs or PFO closures. Now, looking at the outcomes, you have to take into consideration that Leipzig is a center where it trains a number of surgeons. So these results also include multiple learning curves. And despite that, if you see, the conversion rate to a sternotomy was only 1.4%. And in patients with degenerative mitral valve disease, failed mitral valve repair was seen only in 1.6% of the patient, which is actually excellent considering the number of surgeons they've trained there. The 30-day mortality for all comers was 2% and a stroke rate of 2%. And these were all comer patients. So they were also patients with poor EF, with functional MR, patients with dilated cardiomyopathy as well. Recently, we published this long-term outcomes. So we compared resection to the loop technique, but more importantly, I would like you to concentrate only on the overall results. If you see survival of 85% at 10 years, with freedom from cardiac death close to 90%. And if you look at the freedom from reoperation is almost 97% at 10 years. This is just to show you that we can achieve good results with minimally invasive cardiac mitral valve surgery. So it is important also to compare a new approach to the conventional approach. And this was a meta-analysis which assessed a number of randomized as well as matched observational studies. And they again found that there was no difference in the mitral valve repair failure rate between minimally invasive and sternotomy approach, and all the major complications that occur after cardiac surgery, such as myocardial infarction, stroke, reoperation for bleeding, wound infections, renal failure, respiratory failure, etc. There was no difference between the two groups, showing that minimally invasive mitral surgery was safe. What they found was that there was significant reduction in the blood transfusion rates in minimally invasive patients. Atrial fibrillation, though not significant, but it showed a trend towards lower rates after minimally invasive surgery. The readmission rates at 30 days after discharge were significantly lower in the MIS group of patients, and there was no difference in long-term reoperation rates for mitral regurgitation between the two groups. If you look at the in-hospital mortality again, it did not show any difference between the two groups, and even the long-term mortality was similar between the two groups. So thereby showing that it is comparable to the conventional sternotomy approach. Now, if you look at the repair rate, this is a paper from Patrick Perrier, who is an expert in minimally invasive mitral valve surgery. It's his own experience of about 840 odd patients involving anterior, posterior, and bileaflet repairs. And you see that the repair rate was 99.3%. So in a highly experienced when you look at a highly experienced surgeon in minimally invasive surgery, the repair rates are close to 100%. Of course, there would be some selection of patients, but failure rates are very, very low. 30-day mortality was 0.2%. Now, looking at our results from Leipzig, this was published in 2008. 1,500 odd patients, about 1,300 odd patients underwent mitral valve repair, and these were again all comers. So this included patients with endocarditis, included patients with functional MR, ischemic MR, and the repair rate was still about 87.2%. As I mentioned before, for degenerative, it was almost 98%. And the 30-day mortality, again, for all comers was about 2.4%. This is another series from another German center, which does almost 2,000 cases a year. They did a propensity match comparison to look at the echo parameters after minimally invasive and conventional surgery, and they found that mitral valve gradients actually were found to be lower following minimally invasive surgery than after conventional sternotomy, and even the grade of MR, like a larger or significant number of patients undergoing minimally invasive surgery had 0 to trace MR as compared to conventional sternotomy approach. Of course, there would be a definite bias in this study because the anatomy of the mitral, we never match for the anatomy of the mitral valve in propensity matched comparisons, but this is just goes to show that there is the results of minimally invasive surgery are as good, if not better. And this was a long-term survival at 7 years, which again they showed that MIS was better, but I consider it at least as comparable to conventional sternotomy. All pathologies and repair techniques can be performed. As I showed you, this is the chordal replacement loop technique that Professor Moore had developed in Leipzig, and the determination of the correct length of chordae tendineae is reproducible. It's much more reproducible than the freestyle Gore-Tex sutures that is commonly used, especially what Dr. David uses. It's possible to do it through a sternotomy, but it is extremely difficult to do that and reproduce that through a minimally invasive approach. Therefore, the chordal loop technique does provide reproducibility. And you can see again at 5 years, freedom from reoperation of about 96%. So all leaflets can be repaired, and so here you can see the repair rate is almost 97% for the posterior leaflet, 91% for anterior leaflet, and 90% for bileaflet repair. And this includes the initial development phase of the minimally invasive mitral valve repair as well. So these rates have really gone up, and as I mentioned, it's gone up to almost 98% for degenerative mitral valve disease. And if you look at the outcomes again, based on the type of leaflet that is repaired, there was no difference in the survival at 5 years, and there was no difference in freedom from reoperation. And more importantly, you can see it's almost a 96% of freedom from reoperation, even for bileaflet repair. Now coming to Barlow's, as this increases, this is probably the most complex valve to repair, and we published this series of 145 patients, and different techniques were used. As you can see, most commonly the loop technique, followed by the resection technique, with other techniques that were also used, but not that commonly. And we showed that at 10 years, the freedom from grade 2 mitral regurgitation was very close to 90%, and the freedom from reoperation was almost 94% at 10 years. Again, it can be used in all situations. I won't go into the depths of these papers for the sake of time. It's minimal. It can be used in patients with previous sternotomy, concomitant procedures, in obese patients as well, and also very effectively in elderly patients. So, however, there are certain contraindications to this type of surgery, and that's patients with previous right thoracotomy or patients with a very heavily calcified mitral annulus or a large posterior mitral abscess. These are relative contraindications to this type of surgery. And patients with grade 1 aortic, greater than grade 1 aortic regurgitation, delivery of cardioplegia becomes a problem, and therefore usually we avoid doing such patients through the minimally invasive approach. So just to summarize, minimally invasive mitral valve surgery, especially repair, is feasible in most patients with mitral regurgitation, even with complex pathologies, and also in special situations like obesity, reoperations, and LV dysfunction. And it can be performed with excellent results, which are the same or maybe better than conventional sternotomy in certain situations. But of course, it has a learning curve to it. Now we're moving to minimally invasive CABG. If you look at the 2018 guidelines, there's only one mention of minimally invasive surgery, and that is for proximal isolated LAD lesions, or in the context of hybrid revascularization, and that's also a 2AB. The recent American guidelines, they do not even mention minimally invasive CABG. So why minimally invasive CABG? Now we know that the two biggest invasions that we perform or get into when we are doing a CABG is the access to the heart. That's a full sternotomy. And this, of course, increases the recovery time, the infection rates, and this solution is to perform. And we are all well aware of this situation, and we've all seen this picture, and it still ranges between 2 to 6% of our patients. And the solution to that is a mini thoracotomy or port access surgery or endoscopic robotic CABG. The second invasion that we do is using cardiopulmonary bypass, and this obviously involves manipulation of the heart and the aorta, which can cause microemboli. It of course can cause an inflammatory response, especially in sick patients, and the solution to that is an off-pump CABG. And of course, further on, when we perform this operation on pump and arrest the heart by giving cardioplegia, we lead to cell injury and necrosis. And again, the solution to that is off-pump CABG. And even when you perform off-pump CABG and clamp the aorta, it does cause the release of microemboli and can cause stroke. And the solution to that is no-touch aorta surgery using in situ arterial grafting or composite arterial or arteriovenous grafting. So what are the best indications for performing minimally invasive CABG? And these are patients who are at a high risk of sternal wound infections, such as severe uncontrolled insulin-dependent diabetes, obesity, peripheral vascular disease, chronic smokers, patients with severe skeletal disorders like osteoporosis or osteogenesis imperfecta, and patients with long-term steroid use. Then there are patients who are handicapped using crutches, wheelchair dependent, who have amputations of their lower limbs. These really benefit from a non-sternotomy approach. Patients who are heavy laborers like bricklayers or truck drivers, to name a few, they again can get back to work pretty soon without apprehension regarding breaking the wires in a sternotomy or causing sternal dehiscence. Then patients who want to get back to sports as quickly as possible. And finally, at the other end of the spectrum, you have this old frail lady who you would think 10 times before opening her sternum. And such patients are also are feasible and well performed through a non-sternotomy, minimally invasive approach. So there are different surgeries involved in CABG. So when we do it for a single vessel like LITA to LAD or the right internal thoracic to the RCA, it's called the mid-cab approach. Commonly, it's always the LITA to the LAD. Very rarely we do find RITA to requirement to do a bypass only for the RITA to the RCA, sorry, for the RCA. Especially in patients who have undergone previous PCIs maybe once or twice and have required repeat revascularization several times, or an anomalous RCA arising from the left coronary sinus. These are good cases to perform through the right mid-cab approach. So these are papers just to show you that it's not a new operation. Antonio Calafiore in Italy in 1998 published 434 patients, and the Leipzig group also in 2000 published 618 patients undergoing mid-cap surgery. They started this program way back in 1996. So it's almost 25 years since this operation is being performed. So here, just to show you the operation, we take a 5 centimeter incision, go through the 4th or the 5th intercostal space, and this is a special retractor that is used in order to elevate the upper part of the thorax so that it basically facilitates the takedown of the left internal thoracic artery. I usually use the skeletonized technique to take down my grafts, and using the clip and the cut technique. So I firmly believe that burning the thoracic wall usually causes hyperesthesia post-operatively. So here you particularly see the left subclavian vein, because it's a myth that you cannot take down the entire length of the left internal thoracic artery. You can take the whole length comfortably. So then we make a small incision on the pericardium, and the LAD is right there below your incision, and you use a metallic stabilizer to stabilize the LAD, put a shunt in, and perform your anastomosis. And so run along again. So this is the anastomosis being performed. I've increased the speed of the, it's not a fibrillation, I've just increased the speed of the video. And here you can see a LITA to LAD. We always perform flowmetry after the surgery. And here you can see the LITA graft lying comfortably in the thorax. And that's towards the end, and that's the incision that you have at the end of surgery. The similar operation can also be performed on the right side. It's again a 5 centimeter right-sided anterolateral thoracotomy. And again, you use the retractor, specialized retractor, to elevate the upper part of the thorax. And here you can clearly see the right internal thoracic artery, which we harvest with the same technique, again, the skeletonized approach in majority of the cases. And you can just run along here. You can see the entire length of the right internal thoracic artery harvested, and then stabilize the RCA and perform the anastomosis between the right ITA and the right coronary artery. And that's a very elegant way of avoiding a sternotomy for a right coronary artery problem. So recently, long-term results have been published. This is a very experienced surgeon, Dr. Riposini from Brescia in Italy. He published his single surgeon 20-year experience involving about 1,000 patients undergoing the mid-cab approach. And if you see this graph here, at 15 years, for patients who have undergone mid-cab in the blue line, the survival is almost 83%. And those undergoing hybrid revascularization, and those were patients with multivessel disease, is slightly lower as expected because it's multivessel disease. And finally, these are patients who are probably pretty much inoperable through the conventional approach. They've undergone a mid-cab and optimal medical therapy. and the survival is still quite good at about 65% at 15 years. So we published our results recently, so last year, involving almost 3,000 patients over a period of 22 years. And the overall in-hospital mortality was 0.9%, and the survival at 20 years was about 55% in all comers. Uh, but when we stratified it when we compared our survival with the age and sex matched German population, which is shown here in the red line, you see that the curve was found to be even better than the age and sex matched population. There are various reasons for this, but at least it shows that the mid-cap gives you excellent survival close to your normal lifespan. And when we stratified the survival according to the age, we found that patients less than 50 had a survival of almost 94% at 10 years. Those between 50 and 80 at 77%. But what was more interesting was that patients over 80 years, shown in the green line here, at 10 years, these patients had a survival of almost 40%, so which is quite impressive. And just to show you how beautiful this operation is, this was a patient operated in 1997, underwent a LITA angiogram in 2020. And you can see that it's a perfect LITA to LAD anastomosis. I mean, you can't even make out where the anastomosis is. It becomes like a single artery. If you can do one vessel through a left thoracotomy, why not do multi-vessel grafting? And the pioneer of this approach was Mark Ruel from Ottawa and Joe McGinn from New York at that time. They first published their experience of 450 patients with multi-vessel minimally invasive coronary surgery way back in 2009 in Circulation, and they showed that it was a safe and feasible operation. And they followed up this study with a efficacy study that was an angiographic patency study at 6 months, and they found that all LITA grafts were patent, and 92% patency was observed in the venous grafts. The reason given for that was obviously the learning curve, as well as we all know that the attrition of the venous grafts, I mean, they have an attrition rate, higher attrition rate than arterial grafts. We in Leipzig, we thought that the best operation would be to provide bilateral internal thoracic arteries through a minimally invasive approach. The reason being that there's a lot of evidence, at least retrospective evidence, regarding the benefit of 2 ETA grafts being better than 1. It improves survival, it reduces the reoperation rate, and on the right side, landmark paper from Cleveland Clinic showed that as you move away from surgery, the benefit of beta grafting goes on increasing as compared to single ITA grafting. This was a meta-analysis by David Taggart, which again showed the benefit of bilateral ITA grafting, and not only at 10 years, but the paper concluded that it seems to continue into the second decade of life. This is data from the 10-year syntax study, which I was lucky to be a part of, where we showed again that there was a significant difference in mortality in patients undergoing single arterial versus bilateral ITA grafting. We also looked at multiple arterial grafting, and again found that even in patients with multiple arterials, so use of radial artery or the second thoracic artery was associated with lower mortality, long-term mortality, as compared to those undergoing single ITA and veins. The only Achilles heel of bilateral ITA grafting through a sternotomy is sternal wound infection, and the ART trial, which is the only randomized trial looking at only big randomized trial looking at bilateral versus single internal thoracic artery grafting, also confirmed this problem of bilateral ITA, and showed that there was a 2 times higher risk of sternal wound complication and 3 times higher risk of sternal wound reconstruction rates. after bilateral ITA grafting. So we developed the technique of minimally invasive coronary bypass surgery using bilateral ITAs at Leipzig. In Leipzig, we started in 2015, and we performed just a short video of how we do the operation. Again, the first part of the operation is same as the mid cap, so I'll just run along. We take down the left internal thoracic artery, and then we prepare to take down the right internal thoracic artery. So we put a subxiphoid hook, which we don't commonly use nowadays, but we used to. This is to elevate the lower part of the mediastinum, which helps take down the lower part of the right internal thoracic artery. So here you see that the right pleura is open, and how well you can see the right internal thoracic artery, which is taken down in the same standard format, the skeletonized technique. The only difference is that you have to use long instruments to do so. Following this, I performed the Y anastomosis, and here I fixed the left internal thoracic artery on this foot pod of the stabilizer, and this provides a very stable platform to perform the Y anastomosis. And once this is completed, we perform the LITA to the LAD, which is similar to the mid-cap approach. And following the LITA to LAD, we move to the lateral wall. This is the ramus intermedius, which is now opened up, and we perform a side-to-side anastomosis, or sequential anastomosis between the right internal thoracic artery and the ramus. So you can do this even for the high OM, it's the same. And then you move to the deep lateral wall, so the circumflex artery or the PLV, and here you have to use the starfish as well in order to position the heart and then perform the anastomosis. Here is the circumflex artery that is being anastomosed with the end of the right ITA, and this is how the anastomosis looks at the end of surgery. We always confirm all our flows with the flowmetry, and this incision is slightly bigger. It's about between 6 to 8 centimeters, depending upon the size of the patient. So various configurations can be used. You can use an in situ LITA and RITA. So here you see a RITA going to the LAD on the left, and the LITA going to the lateral wall on the right. And in this, you can see that the LITA is going to the LAD in the first picture. And in the second picture, you can see that the RITA is going across to the intermediate. Here is a blown up picture of the same. Here you can see the RITA to the right, to the intermediate artery. And this is the wounds or the scar that you see at the end. And of course, there's no risk of sternal wound infection despite using bilateral ITAs. So we published our paper on this approach, our first 88 cases, where we did about 209 anastomoses. The majority of the patients were LAD and circumflex, and we did about 10% of the patients where we grafted the right coronary artery. 2-vessel CABGs were performed in 65% of the patients, 3-vessel CABGs in 32% of the patients, and 4-vessel CABGs in 2 patients. We did not have any conversions to on-pump and no conversions to sternotomy. We did not lose any patients in hospital. We had no stroke. 1 patient had a myocardial infarction. We had no wound infections, superficial or deep, and we had an overall graft patency about 97% at discharge. Of course, it's not possible to perform this operation in all patients. There are definite selection criteria, and these are the most favorable criteria. It's best to perform in males. And these are criteria that one must observe when one's starting the program, at least himself or herself, till he or she overcomes the learning curve. So body mass index less than 30, cardiothoracic ratio, which is, I think, is the most important, less than 50. So you have to compare the size of the heart to the size of the thorax if you want to perform this surgery off pump. Then left ventricular and diastolic diameter less than 50, relatively normal lung function, avoid a Rita harvest when patients have pectus excavatum or radiation, because it becomes really difficult to do so. And always choose good coronary targets initially. So avoid intermyocardial vessels and heavily calcified vessels, which may need endarterectomy. So the best patients that are suitable for this type of approach is to restrict yourself to left-sided grafting. So if a patient has left-sided disease with a normal RCA, these are excellent patients for such an operation. Or you can also do this in patients who have triple vessel disease, but the RCA is non-dominant or is chronically occluded and is not graftable. Such patients are again very good for minimally invasive multivessel CABG. And of course, you can use the hybrid approach. So you can here you can see left-sided disease and right-sided disease. And so what we did is we did on the right side, you can see this is the Lita Rita performed to the left side, which is perfectly patent. And then the PCI to the RCA was performed, and then you have a perfect result for a patient without opening his chest. So lastly, coming to hybrid revascularization. So just to mention, what is the rationale of doing a hybrid revascularization in patients who are actually surgical candidates? So patients with a high predicted operative mortality, patients who have poor target vessels for CABG or have a lack of conduits, with patients with severely calcified or porcelain aorta, patients who are at a significant risk of sternal wound infections, and very frail elderly patients. These are patients who you might want to avoid conventional surgery, and hybrid is a good option for that. And rationale for selecting hybrid in patients suited for triple multivessel PCI. Well, any patient undergoing multivessel PCI would definitely, I think, benefit more from the long-term survival benefit that a Lita to LAD graft would provide. And therefore, in such patients, one could perform a mid-cap procedure and stent the non-LAD vessels, which is giving the patient best of both the worlds.
I think we can kill it now.
How am I on time? Should I
Yeah,
wrap up?
Yeah, I think that we should probably take some questions, because there are some questions in the chat room.
I'll just show you one slide.
Sure.
Just that that minimally invasive AVR can also be performed basically through a hemisternotomy approach, or through a right anterior thoracotomy approach. And the results have also been comparable between that and minimally invasive surgery. And yeah, so with that, I'll be happy to take any questions that you might
Thanks
have.
a lot. I think Brad, you have a question. Do you want to start asking with about 10 minutes or so?
Sure.
Piroze, maybe I'll ask you to kind of get rid of the slide so we can see each other.
Yeah,
that's great. Yeah, Brad.
Great talk, really fascinating, and nice to see Michael Borger. He's in Toronto.
Yeah,
all the great work that he's done there. I have a question a little bit about hybrids. So, how do you regard doing hybrid? Do you do a lot of them, or do you still like? You didn't talk much about veins here, obviously, because you're going for the arteries.
yeah.
What's your sense of long-term vein patency now versus, doing the hybrid approach with stents in arteries? Because that's obviously another way of doing it.
We've recently published a paper on the syntax 10-year outcomes, where we compared patients undergoing multiple arterial grafting versus single arterial grafting versus PCI. And of course, it's a post hoc study, so it's got its biases. But we did find that there was a significant difference in mortality between multiple arterial grafting and PCI or single arterial grafting, whereas there was not much difference between PCI and so multivessel PCI and single arterial grafting. So that sort of goes to show you that one should perform multiple arterial grafting as much as possible. There's been a lot of data recently on the radial artery, which has also excellent results. And I think the use of a radial artery has the advantage that you do not have higher rates of sternal wound infections, and you can and it's easy to harvest. It doesn't add time to the operation, and so I believe that total arterial or at least multiple arterial should be performed.
Thanks a lot. And Dan, our chief resident, has a question. Dan, are you still there?
Yeah, I am. My question, Piroze, is just, I've heard anecdotally that the thoracotomy incision is actually quite painful in the long term, and I just don't know what your experience has been with patients.
It is definitely more painful in the short term, so like the first 4 to 7 days, but thereafter it goes down. You will have the odd patient who sort of develops sort of a chronic pain syndrome, but that's seen even in a sternotomy. I mean, if you in a sternotomy do not have a well adapted sternum, those patients really have a lot of pain even later on. So I don't think that there's too much difference as far as pain is concerned between. In fact, I would say that long term the pain would probably be less as in a thoracotomy as compared to a sternotomy approach. But yes, the initial 3 to 4 days, I agree, it's definitely more than a sternotomy.
Brian,
Got it.
Brian, do you have a question? So.
Yeah, thank you very much for the talk. One of the important things about minimally invasive procedures is being able to reduce their length of stay in the ICU or in the hospital in general. And maybe if you could just talk through, the rate at which you might demedicalize these patients post-operatively. Are there protocols that you have that accelerate that? Are there some things like certain chest tubes or other things that you might not need to use in a minimally invasive procedure that enable a faster discharge, or is there hospital stay about the same?
Well, it depends upon what your length of stay is for conventional surgeries. So basically, if you're having a length of stay of 7 days for a conventional surgery, then definitely you can reduce your stay to, I would say, 4 days at least. Having said that, the mid-cap, we've started discharging them on the 3rd day. So a mid-cap can be discharged. Multivessel cabbage, we prefer to leave the chest drains in for about 48 hours after surgery, because although they don't bleed, but they have some kind of serous discharge for a longer period of time. So we leave them in, and those patients, again, we could discharge on the 4th day. So surgical AVR and a mitral valve, these are both on-pump procedures. So you could shorten the stay to about 4 days. There are centers who discharge mitral valve surgery patients, the minimally invasive, even on day 2. But they have a fantastic home care system where their care or even their the ECG is monitored at home remotely. So if you have such facilities, then you can even discharge these patients on day 2 or day 3, especially the aortic valve, because you're always worried about the aortic valve patients developing a heart block.
That's interesting.
Yeah.
I know Eric has a question, and then Harindra.
Thanks very much. You've described nicely how this is kind of it's a generational journey. It takes a long time, and you've shown us 25 years since people started doing various forms of minimally invasive surgery. My question's about, because even now it tends to be associated with specific operators or specific centers, more so than being universally applied. What's the, how do you view the needs or requirements for training of young surgeons? Because that's ultimately what causes something to become more disseminated.
Agreed. I totally agree with it. So at the end of the day, training and becoming better is always dependent upon the numbers that you perform. So the more you perform, obviously the surgeon himself gets better at it. And if you have a large case volume, then you have the ability to train the surgeons, train residents. And as I showed you that especially minimally invasive mitral surgery, it's much easier to train the residents because you can, I mean, the residents can see everything that you're doing, especially from the repair aspect of it. And I'd just like to say the way I was lucky to be in Leipzig, obviously, where we used to do sometimes 4 or 5 mitral valve repairs a day. So I had the opportunity of assisting a lot of cases before I started doing that. And the important thing in these operations is that every step of the operation, however simple it is in a sternotomy approach, every step in a minimally invasive approach, the surgeon himself has to sort that out for himself. So even opening the pericardium, how you're going to open it, how you're going to close pericardium, you have to sort that step for yourself eventually. You may, try and emulate or copy the mentor you're learning from. But at the end of the day, when you start doing it yourself, you really find, okay, this doesn't work for me, or, some surgeons are more skilled, some are less skilled to do certain movements. So that at the end of the day becomes a thing that the surgeon has to do himself. But having a large case volume is the most important. And if you have a large case volume, you can train any surgeon to do minimally invasive surgery.
So maybe I'll just go to Angela. If you have a quick question, I'll finish with Harendra's question. Angela?
Yeah, hi. Thanks for a great talk summarizing the minimal approaches now. Can you describe any situations where you've needed to convert to an open? And how do you manage like massive hemorrhage through your access in this environment? Do you ever need to convert?
Yes. So yes, of course you do need to convert. So the sternotomy is always a backup approach. And as far as mitral valve surgery is concerned, the most common reason for conversion is bleeding, and the commonest site where it bleeds from is that when you clamp the aorta, you tend to get the left atrial appendage into your clamp, and that tip of the left atrial appendage sometimes gets injured, and it's sometimes extremely difficult to get it from the right side. And those are the commonest conversions that I had seen, at least in Leipzig. And so we've developed certain tips and tricks in order to avoid that. And definitely, as your experience increases, your conversion rates for that go on decreasing. So that's the most common, point where you need to convert. Besides that, there is not much hemorrhage that you can produce in a mini mitral, because there's only one incision, there's only one cardiotomy, right? The left atrial incision, and that's right in front of you. So that's easily controllable. Yeah, so that's what I feel. The cabbage we've converted to in our entire experience about over 200 cases, and that was again in the first 10 cases that we did, because we had mechanical problems with the stabilizer, and we needed to convert. But beyond that, we've hardly converted to on pump. Maybe again, I think it was only 2 cases which we've converted to on pump cabbage. So of course, as the experience grows and the team becomes experienced, the conversions go down, but it's always a possibility. You can never rule out conversions, and that's always explained to the patient, because he'll end up with 2 incisions instead of 1. So
great, thanks a lot. I really want to thank Piroze for giving us a great talk today. Thanks everybody for coming. For those who need CME credits, just email me and just tell me the dates that you've attended, and I'll send you a certificate for 2021. But just email me will be the easiest. But thanks everybody for coming. Thanks a lot, Piroze. Again, I'll see everybody later next week.
Thanks a lot for having me. Bye-bye.
Bye.